Clinical examination is the most important part in the management of ptosis. A good history and evaluation of a patient in the clinic can give us essential information on type of ptosis, degree of severity, any complicating factors like limitation of extraocular movements and synkinesis, the type of surgery and the amount of correction desired, safety of the surgery, and the expected outcome. Patient or the parents should be asked about the onset of ptosis, the mode of onset, progression of ptosis, any history of trauma, recurrent swelling of the eyelid, allergic conjunctivitis, vernal keratoconjunctivitis, previous eye surgeries, and use of rigid contact lenses. Certain medications can cause ptosis. The birth history, including that of forceps delivery or prolonged labor, any history of diurnal variation, dysphagia, or recent change in voice could be indicative of myasthenia gravis. Ptosis worsening in the morning and improving as the day progresses is characteristic of inflammatory conditions like blepharochalasis. Family history may be positive in patients with Blepharophimosis, ptosis, Epicanthus inversus syndrome. Old photographs are useful in identifying the age of onset and variability of ptosis. The examination of a patient should include the following. The visual acuity should be assessed by age-appropriate methods. Ptosis can cause amblyopia due to astigmatism, strabismus, or form deprivation. Pigmentary retinopathy can be found in patients with chronic progressive external ophthalmoplegia. Visual fields should be done to document peripheral and superior field restriction. Laterality of ptosis, facial asymmetry, any abnormal head posture, chin elevation, and frontalis overaction. These are seen in patients with severe ptosis obscuring the visual axis. Facial dysmorphism in patients with BPES, mask-like expressionless face in cases with myotonic dystrophy. Skin quality should be assessed in dermatochalasis, blepharochalasis, and scars, prolapsed lacrimal gland, floppy eyelids, and rounding of the lateral canthus, brow ptosis, lash ptosis, mechanical causes of ptosis, strabismus or enophthalmos with resultant pseudoptosis, extraocular movements, tear function tests, and corneal sensations. We will now describe the different measurements to be taken in a patient with ptosis. Measurements should be taken in a normally illuminated room with the patient in the upright position, head straight, looking at a fixed point at eye level, at a distance with the examiner's eye at the same level. Frontalis should be relaxed and pupils should be undilated. The palpebral fissure height is measured in line with the pupil in primary, up and down gaze. Margin reflex distance is measured from the eyelid crease to the corneal light reflex. MRD1 is the margin reflex distance from the upper lid. MRD2 is the distance measured from the lower lid. This takes into account the position of the lower lid. MRD3 is the distance from the upper lid in up gaze to the ocular reflex. This was described by Putterman for determining the amount of LPS resection in patients with vertical strabismus, where strabismus surgery was not indicated. Based on MRD1, ptosis can be classified as mild, moderate, and severe. Clinically, the amount of ptosis can be graded by a method described by Beard. Margin crease distance is measured by asking the patient to look down and then slowly look up till the first prominent crease just appears on the skin of the upper eyelid. Lid crease is displaced upwards when LPS aponeurosis is disinserted. It is faint or absent in cases of congenital ptosis. Levator action should be tested by measuring the excursion of the upper lid from extreme down gaze to extreme up gaze with the frontalis negated. LPS excursion has been graded by Beard into the following severity: Patients with congenital ptosis with true dystrophy of the muscle. In them, the LPS action is poor and they require a frontalis sling surgery. In acquired cases, the LPS action is generally good. LPS action not only determines the type of surgery to be done, but also the amount of ptosis to be corrected without causing over or undercorrection. Tarsal platform show is measured in the primary gaze. It is the amount of tarsus visible between the lid margin and the eyelid crease. Brow fat span is measured in the primary gaze with the lower border of the eyebrow to the upper lid crease. Vertical lid height is the entire span of the upper lid measured with the patient looking downwards from the superior orbital rim. The vertical tarsal height is measured after everting the eyelid, in the center, preferably using a slit lamp. Bell's phenomenon is tested with the patient looking in primary gaze. The upper eyelid is lifted up to the superior limbus and the patient is asked to gently close his eyes. Normally, the eyeball moves upwards and outwards on closure of the eyes. Grading of Bell's is based on the amount of cornea disappearing under the upper eyelid. Lagophthalmos is measured by asking the patient to gently close the eyes. Lid lag may be present in patients in whom Mueller's is strong. Such patients are likely to overcorrect after surgery. Herring's phenomenon is based on the Herring's law of equal innervation. When the ptotic eyelid is manually lifted to the superior limbus, the eyelid of the other eye droops. The chances of ptosis becoming apparent in the seemingly normal eye should be explained to the patient prior to the surgery. Frontalis action is tested by asking the patient to elevate the eyebrows as much as possible in the primary gaze. Patients with poor frontalis action like facial palsy and post-traumatic ptosis will not benefit with a tarsofrontalis sling. Fatigue test is done in cases of suspected myogenic ptosis like Myasthenia Gravis. There are two ways of doing the test. In the first one, the patient is asked to look up for 20 seconds. The upper eyelid will slowly come down. In the second test, the patient is asked to follow the examiner's fingers as he rapidly moves it up and down 10 times, and the palpebral fissure height is measured again in primary gaze. Difference of 2 mm is significant. For eyes test, ice pack is placed over the closed eyelid for 2 minutes. The palpebral fissure height is measured immediately. An improvement of 2 mm is considered significant. Synkinesis should be documented by noting the improvement in ptosis with the movement of muscle of mastication. Most commonly, it is with the nerve to lateral pterygoid, and that is called Marcus gun jaw winking phenomenon. Amount of synkinesis can be classified as mild, moderate, and severe. Synkinesis can be graded clinically based on the improvement in position of the ptotic eyelid. Every case of ptosis is challenging and different from the other. It must be tackled individually. A good history and correct examination can help formulate the management approach, both to the satisfaction of the surgeon and the patient. So don't let ptosis bring you down.